Good evening, everybody. We're really pleased this evening to have Graydon Simmons with us talking about managed alcohol programs, something that we've been working our way towards as a session for quite a while. I know we had some logistical organizing to do around your call schedule. So thank you, Graydon, for making yourself available. So we'll be talking about managed alcohol programs, example operations, successes, and challenges. Graydon Simmons is a general internal medicine physician working at the Ottawa Hospital and Ottawa Inner City Health. He completed his medical school at Queen's University and internal medicine and general internal medicine training at the University of Ottawa. He provides inpatient and outpatient general internal medicine care, and he also works part-time at the Ottawa Hospital's viral hepatitis program. I just would like, before we go further, to start with our land acknowledgement, and then we'll review the course of our evening. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawendarons, or Neutrals, and is home to the Dish with One Spoon Treaty. Medify recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. Medify respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And with that, again, I'm really pleased to welcome Graydon. As usual, our talk will be about an hour, and I invite people to post comments and questions in the chat. I'll generally save them up unless there's something that's really pressing, and look forward to having more conversation towards the end of the talk.
Thank you very much for the introduction. So the kind of overview for today's talk in terms of a title is that I'm going to talk about managed alcohol programs in some generalities, but also in terms of some of the specifics from my organization's experience with them. So we'll go over, example operations, successes, and challenges. And in terms of an agenda for the talk, beginning, we will go over the history and evidence behind managed alcohol programs, not in too much detail, but just giving people a brief summary, especially because I can see in the chat that some people have mentioned that they have really no experience. And then it's also exciting for me because there's a few people that have piped in that they actually work in MAPS themselves. So that's great. And then, like I mentioned before, we'll go into the practical aspects of how we deliver care at our two managed alcohol programs currently with Ottawa Inner City Health. And then at the end of the presentation, before the Q&A, I'll just talk about what we are talking about behind the scenes at our managed alcohol programs in terms of challenges that we're currently facing and maybe future directions that we hope to maybe take our managed alcohol programs, or that the growing number of people researching managed alcohol programs in the country start to consider. And then we'll do the Q&A with questions from the chat or anyone that wants to pipe in. So just to give you a brief background about managed alcohol programs in my context, I'll tell you first about Ottawa Inner City Health. So it was a health organization that was established in 2001. And the main reason why it developed was that there was a group of healthcare providers in Ottawa who noticed that there were a bunch of people who were chronically homeless that were not having their needs addressed, despite the fact that they were high users of healthcare services and other social services within the city. As well, when these providers got together to discuss this, they recognized that, this was quite tragic, that there was many people living with really severe mental illnesses, substance use disorders, and just generally chronically homeless that were otherwise barred from receiving services in other places, and that something needed to be done to equip them to be able to receive healthcare services. Right now, Ottawa Inner City Health runs thanks to many different partner organizations, and this is just a sampling of them, but it goes to show you how the complexity of an organization like mine that provides care to a very marginalized group relies upon many other groups within the city of Ottawa. And this is comparable to other organizations across the country, I think, that do similar styles of healthcare for marginalized folks living in the inner cities that are either vulnerably housed or chronically intermittently homeless. And I would classify the two major styles of programs that we have as shelter-based programs and supportive housing programs. To briefly describe what a shelter-based program is, a healthcare program that is embedded within the homeless shelter itself. And the goals of our programs that we have embedded within homeless shelters are to deliver as much healthcare as possible within the shelter. A lot of the clients that we service make requests to try to bring everything centrally to them where possible and as safe as possible. And we attempt to assist them with their healthcare challenges while they are also looking to obtain independent housing. Our supportive housing programs are when we have clients who are chronically homeless and unfortunately their complex healthcare needs due to mental health, substance use, and physical health exceed what would be possible in independent housing. So the supportive housing programs are created with help of some of the partners organizations that were listed in the previous slides, where they coordinate housing for the client, and Ottawa Inner City Health provides the daily health care. In addition to those shelter-based programs and supportive housing programs, we also have multiple other programs that we won't be discussing in detail at today's talk, but Ottawa Inner City Health is a very large organization with many different programs. It's predominantly a nurse-led organization that is contributing to all these things that you see on this slide. But our managed alcohol programs exist in two of our supportive housing programs, and that's what I'll be talking about a little bit later. At Ottawa Inner City Health, and we'll talk about some of these roles in the context of the managed alcohol programs. We have a number of different roles. So client care workers is a term that we use, or CCW is the acronym. I loosely describe it as a unique healthcare role that's somewhat in between a PSW and an RPN. It's a PSW that's been given additional medical training to be able to administer medications, take vitals, things like that. Then we have a number of RPNs, as well as nurse coordinators, nurse managers, physicians like myself, and then an administrative office with a management team there. And this slide, I should note, does not include employees from our partner organizations who also work at many of the sites that we provide our services. So now that you've gotten kind of a brief background on the context that I come from in terms of my practice environment with Ottawa Inner City Health, we'll just go through a tour of managed alcohol programs in terms of their history and evidence in Canada. The main discussion in the literature about managed alcohol programs in Canada really starts in the late 1990s and the early 2000s. Around this time, clients in homeless shelters that were living with alcohol use disorders were a top issue in the country. And that was because there was many people that were experiencing significant morbidity and mortality from their consumption of both beverage and non-beverage alcohol use. If people aren't familiar with the term non-beverage alcohol use, it's kind of a catch-all term for when someone living with an alcohol use disorder might have to resort to consuming mouthwash or rubbing alcohol or any other forms of alcohol that was not created for the intent of consumption by a human to avoid alcohol withdrawal. And at this time in homeless shelters in the late 1990s, early 2000s, there was some success with kind of the typical abstinence-focused management strategies of the day, but clearly there was a distinct population in homeless shelters that abstinence-focused management was not successful at all. And what people were noticing is that for these clients in the homeless shelters, they just continued to have recurring hospitalizations, use of EMS, frequent encounters with the police, and were unable to ever really get out of a loop and find themselves being able to obtain independent housing. Around the same time, researchers and people working in this space were beginning to talk more and more about harm reduction policies in Canada. And especially, this is often when different organizations were really starting to boost their harm reduction management in the setting of intravenous drug use. And as a result, there was some early shifts where lots of people that were working in the harm reduction space. We're educating police, lawmakers, and the general public about harm reduction and trying to address many of the common misconceptions. As well, there was this really big event in Toronto where an inquest was made into the deaths of many men that were facing homelessness with severe alcohol use disorders that died basically freezing to death outside the shelter. And that, prompted a lot of people to reflect on how, why were so many men with alcohol use disorders dying frozen in the streets in winter? What was going on there? And it led to a discussion with providers in Toronto that if you were someone living with a severe alcohol use disorder, actively consuming alcohol and staying in homeless shelters, you had a lot of barriers to care. Essentially, the options at the time were you could consume a lot of alcohol in the daytime so that by the time you had to check in for your shelter bed in the evening, you'd be abstinent from alcohol because consuming alcohol in the shelter was not possible, and then go through kind of a risky period of time where you might wake up in the morning with a significant stage of alcohol withdrawal because you weren't able to consume alcohol all night, or you had to avoid the shelters entirely and face sleeping in the streets or sleeping in the rough. So with those two options faced to people living with severe alcohol use disorders in homeless shelters, people postulated maybe there could be a third option. And that's where managed alcohol programs come in. They are deemed, to be a harm reduction intervention. They're for patients living with severe alcohol use disorder, so not a first line option for, a mild alcohol use disorder or, high risk drinking. And the definition is pretty general. We'll get into this a little bit, but the managed alcohol programs across the country are all a little bit different from each other. Many of them can be clustered into one type of grouping, others another type of grouping. But in general, I think something that unifies all managed alcohol programs is that participants are provided regular administrations of beverage alcohol and some form of supportive programming. I use the loose term supportive program because in some programs that includes housing, and other programs that includes, workshops on life skills or helping coordinate healthcare. It can be a very, very wide range. So now looking into, kind of officially a retrospective look at how MAPs have developed in Canada. The first official map that everybody kind of comments on opened in Toronto in 1998 at the Seton House. And there is a group out of the University of Victoria that's running a study, the Canadian Managed Alcohol Program Study, or CMAPS, that's keeping track of MAPs. I put the link at the bottom of the slide. And as of their most recent update in the beginning of February of 2022, there were 42 MAPs that are either running or are essentially in development at the time of that study update. And they're located in a variety of settings. So some managed alcohol programs are like the ones that I'm used to seeing, where they're embedded within a supportive housing program. Others are embedded within homeless shelters and hospitals. Some have community sites. So there's many different locations now in Canada that managed alcohol programs can take place in. The evidence that's there is okay. I think I'm going to guess that people attending a Medify talk in the addictions medicine world, we recognize that addictions medicine evidence is often different than other areas in medicine, and the evidence is growing. But where it is now, I would say it's fair to say that the evidence is building that managed alcohol programs are an effective management option for people who are facing homelessness and living with a treatment refractory severe alcohol use disorder. And specifically, there are studies that have been able to demonstrate that MAPs have the potential to reduce a participant's use of emergency medical services, hospital services, and police services. And to those that are in Northern Ontario on this talk, here's a nice reference to the fact that there was a great cost-benefit analysis of a 15-bed managed alcohol program in Thunder Bay that showed significant cost savings for the participants. So participants, when compared to controls or when compared to their costs pre-participation in the program, the annual cost savings were multiple thousands of dollars. So pretty substantial when you think about that cost is often what people use to navigate speaking with administrators and stakeholders and lawmakers to create a map in their community. That is kind of a quick tour of the evidence. I think in the Q&A session, if people want to know about specific studies that I've heard of or have heard of other studies, we can get into that. But just going to show that the evidence is in the kind of, I would say, early phases, but some established evidence to show that this is a growing option for the right type of participant. And now we'll get into some of the details on the practical aspects of how the current Ottawa Intercity Health Managed Alcohol programs deliver their care. So in the beginning, Ottawa Intercity Health had one managed alcohol program, and that was located within a shelter in the downtown core of Ottawa. With time, that program was deemed to be successful and was demonstrating that it was able to stabilize certain clients' alcohol use disorders. And quickly, the beds filled up, and the clients living in the program were not really destined to go anywhere in the short term. So then as a result, a second site was added, and that led Ottawa Intercity Health to kind of have this framework of approaching the participants that we place in a managed alcohol program. And I would kind of summarize that framework or care pathway into three phases. The first is that a participant is considered for a trial and an attempt at stabilizing their alcohol use. Then with time, we are looking to optimize their alcohol use disorder for the long term and optimize their healthcare and just kind of engage them in chronic ongoing care. And then the third phase is eventually there may come a day in which the participant in one of our managed alcohol programs wants to talk about their goals of care and kind of long-term life planning. Today, some of those managed alcohol programs that I talked about just a few slides ago are no longer present. So things have changed with Ottawa Intercity Health. And now we really have two main managed alcohol program sites, one at the Richcraft Hope residence and the other at a residence that's called the Oaks. I put a star at the bottom of the slide because we have a hospice unit that was briefly mentioned on one of the earlier slides. And patients at our hospice unit are able to participate in a managed alcohol program, but it's not really an official site where we regularly admit new participants in a managed alcohol setting. It's really for clients that are living with severe alcohol use disorders in the inner city that ultimately need end-of-life care. And while they are receiving their end-of-life care, if it so happens that their care would be benefited by participating in a managed alcohol program, then that's feasible at our hospice unit. But the bulk of our managed alcohol participants are at the top two residences. So just to give you kind of an overview of what this looks like, because this is another example of how Canadian MAP sites really differ, is their size. At the Richcraft Hope residence, it's a supportive housing program. So you can see here in this photo, it essentially looks like an apartment building. And that's really the hope with our supportive housing programs, is they don't necessarily look highly medicalized. It's a 42-bed supportive housing program open for all genders. It's our newest MAP location for Ottawa Intercity Health and opened quite recently in 2021. It's located in the Vanier neighborhood on the east side of Ottawa's downtown core, for those who are roughly familiar with Ottawa geography. At this site, some but not all residents participate in a managed alcohol program. So it's not a criteria for someone to move to this supportive housing program that they have to be interested in participating in a managed alcohol program, but many of the clients do. And in terms of how the beds are allocated, there is a priority given to Indigenous clients. If we're looking to decide between a next set of clients to admit to the program, priority is given to candidates that are from Indigenous backgrounds. And in comparison to our other MAP site, the clients at the Richcraft Hope residence are generally younger and medically less frail. They're also clients who are still hoping to be close to the downtown core. The other MAP site that we have is a little bit more removed from the action. So you kind of use that term loosely, but if a client says to us when we're trying to ask them if they would like to participate in a managed alcohol program, and we talk about our different sites, often the clients that really still want to be close to a community that they may have built in the shelter system or in Ottawa's downtown core, then they often lean towards a spot at this managed alcohol program site. The other managed alcohol program site is the Oaks. This is now our more long-standing MAP site. It opened in 2010. It is also open to all genders, and it has 55 beds. The clients that are at this site are generally ones that have been known to Intercity Health for a very long period of time. They've participated in a managed alcohol program for a very long period of time. Some of them have been participating since the site opened in 2010. And as a result, they're often more medically complex as well as medically frail. In comparison to the Richcraft Hope residents, the vast majority of residents participate in a managed alcohol program at the site. And I would say generally those that don't participate are because they formally participated, but then eventually deemed that they no longer wanted to participate, as opposed to they came in from the outset not living with an alcohol use disorder or not interested in participating. So this now we'll start to get into kind of the practical aspects. I imagine there will be some kind of FAQ type things about how we specifically administer the program. So feel free to write those in the chat and we can chat about them at the end. Somebody I can see here in the chat noticed mentioned was the Oaks featured on the Fifth Estate. It was. So there is a couple of YouTube videos about Ottawa Intercity Health's managed alcohol program sites. And I believe the way that it was referred to on the Fifth Estate, they heavily mentioned the fact that we use the term POUR. So every alcohol administration at Intercity Health MAP sites is the POUR. And I think they really kind of liked to use that term in their branding when that episode came out. So speaking of that, how does alcohol get administered at Intercity Health MAPs? Alcohol is administered every hour on the half hour from 7:30 in the morning to 9:30 at night. So that totals up to 15 administrations per day. And the standard administration of alcohol is a pour of 5 ounces of wine. And it's wine that is actually brewed in-house by the partner organization. The partner organization for both of our MAPs is the Shepherds of Good Hope, and their housing staff team brews the wine. And it's not something that I'm involved with or any of the Intercity Health workers are involved with, but I was actually at the Richcraft Hope residence today and I was walking by the wine brewing room. So I thought I would take a picture to show you what it looks like. So there's housing workers that intermittently will do the kind of home brew wine method and transfer it from these barrels and do all the appropriate things to make beverage alcohol. And then they aliquot it out into clear containers that have spouts on them, and they also have draft pumps at the sites where the 5 ounce pours are given from. And a key here is that 5 ounce is an important thing that often for me as a general internal medicine physician, when I'm teaching medical students or residents about alcohol administration or any other healthcare provider that hasn't really learned about it formally, is that 5 ounces is a standard drink equivalent. And in our programs, if a client is not someone who naturally drinks wine and has the finances to purchase their own alcohol, they are allowed to bring in a standard drink equivalent that is not wine and hand it over to the staff, and then they will be administered that in place of a wine pour. I would say most of the clients that do that in our programs typically don't do that for all of their 15 alcohol administrations per day. It's usually a couple or at certain times of the year. The other thing that is to note about our standard pour schedule is that typically the morning alcohol administration is a little bit more. It's typically 7 ounces of wine, and that's to account for the fact that often clients are having withdrawal symptoms in the morning because we don't really have a long-acting alcohol that can address that interval time between going to sleep around the time of their last pour after 9:30 at night to the first pour in the morning at 7:30. In terms of how the alcohol gets administered and does it always get administered, there are many reasons why a client may not receive their pour at the half-hour mark on the hour when a pour is due. And that could be because of the fact that the client is sleeping in their room. It could be from the fact that the client is out and about running errands or seeing friends or whatever have you. They could be timed out of the program due to behavioral issues. And also clients could be given what's known as a special pour. And this is something that the team that administers the alcohol will determine if a client's seeming like they're trending towards a level of intoxication that's inappropriate to continue administering them alcohol. And a special pour for us is basically a half and half mixture of the program wine and water. And then also with time, clients and the team that is heavily involved in determining their alcohol administration amount may also decide that they no longer wish to receive a standard drink amount. So if a client is frequently having challenges with being intoxicated and getting timed out of the program, certain clients in their poor administration record, you will see denotation that they're getting 4 ounces of wine or 3 ounces of wine. And that's because ultimately that is sufficient for them for their alcohol use disorder to prevent withdrawal, but at the same time avoid intoxication. On an average day at one of our sites, so the one 55-bed site and the other 42-bed site, we typically have 2 to 3 housing staff that are working. These are the people that are directly involved in the administration of alcohol. They are physically pouring out the drinks and supplying them to the clients and marking into essentially a medication administration record for those that are used to that term from a hospital setting about the alcohol administrations. Then we have 2 or 3 of that unique healthcare provider role, the client care worker. They are involved in administering the clients their medications, assessing vitals twice a day, and just doing a general shift assessment twice a day. And then we have one nurse coordinator that is kind of overseeing everything. This is an RN that's usually, as a physician, my main point of contact at our managed alcohol program sites. So that's kind of the number of staff that are involved on a typical Monday to Friday. How do we decide from our prospective participants who we think should be given a chance to participate in one of these one of these programs? These are kind of loose criteria, and we talk about them at rounds. There's no definitive set criteria, but essentially what we're looking for when we discuss potential new candidates to be admitted to one of our managed alcohol programs is, do the participants have an evidence of a severe alcohol use disorder that's treatment refractory? And is their severe alcohol use disorder leading to a significant consumption of emergency medical services, the emergency department, and hospital services? It's not to say that people living with severe alcohol use disorders that don't consume a lot of those things or are not treatment refractory don't deserve some form of management for their alcohol use disorder. It's just that we prioritize the most treatment refractory and the highest need. As well, because Intercity Health's mandate is to work with those that are facing chronic homelessness, then people have to be homeless to participate. This is not a program that we use as a bridging measure. If someone was housed and living with a severe alcohol use disorder, this is not seen as a way for them to maybe stabilize their alcohol use and then return to their previous independent housing. And I should note that there's an important differentiation there. People do ultimately go on from our managed alcohol programs to live in independent housing, but the key difference is just that they came from a shelter-based environment and not from a previous independent housing environment. The other thing is that because our managed alcohol programs are at our supportive housing program sites, the clients generally have to be known to Intercity Health programming. So we occasionally receive phone calls from local hospitals knowing that we have managed alcohol programs, and they will inquire if we would consider a patient that they know of for admission into one of our managed alcohol programs. We generally don't do that if the client's not familiar to us. And that's because the supportive housing programs are, like I said earlier in the presentation, essentially an apartment building. There's a community there. So if we bring in clients that we don't know anything about their past medical history, social history, mental health, anything like that, there's a potential that the client may not gel well with that program, and that can be very disruptive to the other participants that are already in the program. In terms of exclusion criteria, there's not really necessarily an obvious exclusion criteria up front. These are more exclusion criteria as participation in the program goes on. But if a participant is demonstrating a clear lack of consistent engagement in management of alcohol, so they're essentially never showing up for any of the poor administrations and obtaining program alcohol and consistently only drinking outside alcohol, and when there's discussions around their alcohol consumption, if they say, I'm not interested, this managed alcohol is not helping me at all, then generally that's considered a time to reevaluate if the program is them. The other thing would, major thing would just be in general behavioral issues. If there's challenges with their behavioral interactions with other clients, with the staff, their ability to demonstrate self-care in terms of engaging in their healthcare, or just participating in routine self-care items like bathing and eating and accepting conversation and input from the staff at the program sites. And that makes us review their participation, as well as the fact that since they're living in these apartment style buildings, they have to also manage their supportive housing unit to a certain level, or the partner organization that coordinates the housing unit may deem that they have to be evicted due to damages in the room or failure to maintain a cleanly room or something like that. As well, at our managed alcohol program sites, there is a nominal fee that participants have to pay for the rent of the room as well as for the alcohol. It's by no means something that is felt by all of the people that develop that fee to be taxing on. Typically, most of the participants have some form of government assistance income. It's more just to encourage a level of engagement and demonstrate a level of commitment to the program. But there are participants who, with time, after months and months and months, fail to provide those nominal kind of monthly fees, and they're eventually asked to leave the program. Now, in terms of how a participant goes from being a prospective candidate to actually the steps in which they're admitted to the program. So once we've identified somebody that we think is going to meet those inclusion criteria, is not likely to ultimately go on at the outset that we think to develop those exclusion criteria, what does their first couple of days in one of our managed alcohol programs look like? Typically, that nurse coordinator that I mentioned as a physician that I'm directly liaising with will have an intake consultation. The nurse coordinator has probably generally heard of this client, but since they don't necessarily work at one of our shelters and a shelter-based program that's directly client-facing for those that are living in homeless shelters, they've never maybe personally met them and gone into their past medical history and social history. And that's really important for that nurse coordinator to get familiar with the client so they can help build a care plan for them. So in this admission consultation, they'll meet the client, go through their past medical and social history, and the next step, they will also importantly review their recent alcohol consumption. And this is really key. This is somewhat comparable in how medical providers that look after people with opioid use disorders will begin to estimate what types of opioid agonist therapy should be prescribed. When the nurse coordinator does this assessment and reviews a client's recent alcohol consumption, it gives them some estimate as what the starting point for their alcohol administration should be. So while there is the capacity for every single client participating in the program to receive an administration of 5 ounces of wine every hour on the hour for 15 times in a day, it's not as if all clients receive alcohol that many times. And after they review the client's recent alcohol consumption and talk with the client, they'll usually establish a plan for the initial amounts of alcohol that that client's going to be administered in the first few days in the program. And they also will establish a plan for the client's healthcare and social goals. So usually that nurse coordinator is trying to get a sense of if you have any guesses as the client. Some clients have none because their alcohol use disorder is their main focus. But if your alcohol use disorder was stabilized, what else could we help you with in terms of your health or your goals, in terms of your social life, or kind of the other parts of your life outside of your healthcare, whether that's reconnecting with your family, ultimately seeking independent housing, items like that. After that admission phase, now we're kind of getting into those pathways that I mentioned earlier that were developed out of Inner City Health's experience with managed alcohol programs. So this is now officially the client is in the trial and stabilization phase. So in that phase, on a daily basis, the housing staff at the supportive housing programs are the ones that are administering the alcohol. How do they decide to do that? How do they determine if a client shouldn't receive alcohol for an intoxication or should receive a special pour? They have basically a comparable level of training to assess for alcohol intoxication, like they got their smart serve which for those on the call that may not be from Ontario, SMART serves a generic term for kind of the certificate that people have to get to administer alcohol in a bar or a restaurant. So that's often what the nurse coordinators and client care workers will remind everyone at the shelter is if at the end of the day, this person showed up to a bar and they did not look like they should be served alcohol, they should not be served alcohol. In the early days, the CCWs and the nurse coordinators often comment that new housing staff that are just getting familiar with our managed alcohol programs often need assistance with assessing the clients. And often the nurse coordinators find that people are too eager to give alcohol as opposed to the opposite, in the sense that they're cutting clients off too early. The nurse coordinators are often reminding people, no, it's okay. You can time the person out for an hour. There's another hour that will come by that if the person's clearly demonstrating signs of alcohol withdrawal, there's another opportunity very shortly. In terms of what the first few days or weeks can look like in this trial and stabilization period, usually the CCWs and housing staff are highly focused on these new clients in our managed alcohol programs to assess their interest in kind of ongoing engagement. Sadly, it's not surprising that this is quite a disruptive experience to this person. There's a lot of flexibility that they lose, sadly, going from being able to drink alcohol whenever they pleased to now being admitted in a program where the alcohol administration is quite regimented. We can often see this being a challenge in people that are typically used to binge drinking as opposed to drinking at regular intervals on a daily basis. And I'll talk about that as a challenge later. So there's a high level of focus on these new clients admitted to the program in an effort to try to stabilize their alcohol consumption. And our nurse coordinators are generally titrating the amount or frequency of alcohol administrations multiple times per week in the early trial and stabilization periods. Common early issues that these staff members, the housing staff, the CCWs, and the nurse coordinators see in our clients when they're admitted is the fear to request for additional alcohol. There can be multiple reasons why a client may have that, just lack of familiarity in the program, a sense of embarrassment that it's something to be ashamed of for wanting to have more alcohol administered to prevent withdrawal, and that the goal of the program is abstinence oriented. The list goes on. We've had some early clients, as an example, that instead of requesting for more alcohol, have actually broken into where the alcohol is stored at night to try to consume alcohol, or have stolen money from other clients in the building to go and buy outside alcohol. And often that team at the managed alcohol program site has to just reassure the clients, you're welcome every day to come and contact us and reassess your alcohol administration. We're happy to meet your needs as long as we're doing it in a safe way that's not encouraging intoxication and complications from that. But our goal is to avoid you feeling the need to do things like stealing alcohol or drinking outside alcohol to avoid alcohol withdrawal. And sadly, another thing that's very common in the early trial and stabilization phase is severe alcohol withdrawal. And that's just because many clients, the change from their previous drinking regimen is so different to how alcohol is administered in the managed alcohol program that it's not surprising in the first couple of days for a client to experience severe withdrawal symptoms as we attempt to rapidly meet their alcohol needs and adjust their drinking style sometimes to the program schedule. So that is something that I think has to be highlighted, and we'll talk as well in the challenges and future directions phase, that there is some forced drinking style with this regular style of drinking every hour on the hour for certain clients, and that can put them at risk of alcohol withdrawal. The other thing that's very common that the teams embedded at the MAP site see is early participants frequently going off unit to drink outside alcohol. And another common issue is the fact that at our managed alcohol program sites, the only option for alcohol provided by the program is wine. So there's many participants who expect that they'll be able to adjust to wine, or don't really expect to adjust to it and don't like it. But at the end of the day, it's the best option available. And there can be lots of frustrations in the beginning about the fact that the program serves wine, and lots of comments made to the staff about the fact that the wine isn't strong enough, and it must be watered down, and kind of fears and myths like that. In terms of the next phase, after a client is officially stabilized and it looks like they're going to continue to participate in our managed alcohol programs, usually that same team of people, the housing staff, CCWs, nurse coordinator, are now looking to get into a steady state for the client's alcohol administration. They're hoping that the schedule and the amount of pours is not changing necessarily on an every couple of day basis. The nurse coordinators that I know that are currently working at our MAP sites are generally hoping that maybe they have to make changes 1 to 2 times per month. And also in this phase is when the CCWs and nurse coordinators are looking to make progress with those initial goals, or maybe new goals that the client have made in terms of their physical and mental health. At this stage in the program, we can still have ongoing challenges with morning withdrawals. And we've briefly talked about that a little bit so far. That's something that's always a challenge, that window of going to sleep after the last pour at around 9:30 at night to the first pour in the morning at 7:30. Many clients come down in the morning with significant periods of alcohol withdrawal. For all the physicians or nurse practitioners or people involved in prescription medications, or nurses on the call involved in hypertension management, for me as a physician, if anybody calls me about a hypertensive patient in the morning at a MAP site, I'm always going, well, have they received their first pour of the day? Because it's very possible that their hypertension reading is because sadly they're in morning withdrawal. Another common issue is even though someone's alcohol use can be stabilized, many clients still will go off-site and then maybe drink at a higher level and become intoxicated with outside alcohol. And many of our clients at our managed alcohol programs sites use other substances. So clients frequently can still get timed out, even though on a steady average day, their alcohol administrations are in a good state. There can be certain clients that still have issues with intoxication for outside the program reasons. We can also see acute complications of alcohol consumption, like falls and intoxication or behavioral challenges. These are things that we try to optimize with time, but in the early phases of program participation, when the team is just getting used to the client after they've reached a steady state with their alcohol schedule, these can still come up on a frequent basis. Another challenge that we see, because many of the clients living with severe alcohol use disorders coming from a chronic or intermittent homelessness background, they are quite medically complex. They can have many instances of intercurrent health problems. So they develop a pneumonia or a UTI, or they get an infection in their skin from a bump on their knee from a previous fall. And when that happens, the medical team, typically the nurse coordinator and the physicians like myself, are trying to balance the risk of withdrawal with the fact that during an acute illness, a client may have a decreased level of alcohol tolerance. So we're trying to make sure that we recognize that this person and their body has become dependent on alcohol, and we administer them alcohol to avoid withdrawal, complicating their current medical illness, but at the same time also recognize that they may not be up to their usual amount of alcohol. So there are clients that, due to their own past history with healthcare services, are very resistant to the idea of going to healthcare centers to receive care. And like I mentioned at the beginning of the presentation, a lot of our clients are coming from inner city health programming within the shelters, where we try to bring as much care to the client as possible embedded within the shelter. So they're very used to receiving care. As a result, we can have clients that are very sick with something like a pneumonia at one of the managed alcohol program site, and they're so sick that they're not able to make it down for their administrations of alcohol. So in certain contexts, we will have the housing workers, CCWs, or nurse coordinators actually bring alcohol to the clients to, again, avoid the risk of withdrawal complicating their medical illness. And sadly, ultimately, if a client does get too sick, or it's very clear to us from the outset that they absolutely have to go to a hospital, then we usually try to prepare letters to hospitals that explain that this is a person that, to our knowledge, is interested to continue participating in a managed alcohol program, is not interested in pursuing detoxification from alcohol, during their hospitalization if that's medically appropriate and medically feasible. And that's something that we'll also chat about in the challenges section. Then moving on to the final section of our MAP care pathway, which is kind of the goals of care and long-term planning. Once a client is quite stable in the program and usually has participated in the program now for a couple of years, usually our team is trying to reassess what is the client's plans. Are they someone who, now that their severe alcohol use disorder has reached some level of stability, are they ultimately aspiring to pursue placement in independent housing? Are they planning to participate in a managed alcohol program long term, or are they hoping for some other type of option? And do they know the risks that are probable with continued participation in a managed alcohol program? Because as we discussed, it's a harm reduction program. So sadly, the harms still will come. We're just trying to slow them down. So once a client is quite stable and can maybe start to think about some of those long-term plans, we'll usually want to talk with them about the health complications of continued participation. We can go back to these because I'm just keeping an eye on the clock. I prepared some slides preemptively about frequently asked questions. So I'll want to make sure that we move on to the future directions and challenges section of the presentation. So I'll come back to these as needed. Common questions that I get about our managed alcohol programs are: what are the nurse coordinators coordinating? What do physicians do? How often are clients intoxicated? Do we record whether clients are drinking outside alcohol? How is the actual amount of alcohol administration decided? Are people allowed to detox at our sites? What types of clients stay in our managed alcohol programs? And what type of clients ultimately leave the programs? Yeah, those are quick things to maybe put inside your brain. And if that triggers a question, type it into the chat or bring it up when we get to the Q&A portion. But now I'll just go through some of the challenges that I've hinted at already in the presentation with some example cases. And then I'll also go through some of the future directions type questions that we've been talking about with our maps at Intercity Health. So the challenges, I would say, as a physician and thinking of things from a medical lens that we see on a frequent basis for our clients, is that, again, we are only reducing the harms of alcohol, but we still see those harms quite regularly. So everyday issues that commonly arise at our MAP sites are falls and fractures. The teams are doing their best efforts to ensure people aren't intoxicated, but even someone that's not overtly intoxicated still has that possibility to have a higher chance of falls and subsequently fractures. And unfortunately, continued alcohol use puts you at a higher fracture risk. We have lots of clients that struggle with hyponatremia because of the fact that they consume predominantly alcohol and can have issues with low intake of food, as well as clients' livers deteriorate and exacerbated by their low food intake. We have frequent issues with hypoglycemia at our MAP sites. And due to the high fluid consumption, many of the clients at the MAP sites struggle with edema. An example challenge and way that we address it at our MAP sites is the eating list. So the housing staff and CCWs keep a separate list where they go around and ensure that clients are eating multiple meals a day. And that's because many of our MAP clients have really poor appetite and poor food intake. At a supportive housing program, meals are offered at both of our sites, but the clients that don't participate in MAPs, we don't record their food intake. It's not like if someone's admitted to hospital where commonly food intake is recorded. But for certain clients, when they begin to have medical complications over and over again from poor food intake, we begin to record it. Then we also see long-term complications of alcohol use. So we often notice that with continued participation in our MAPs, clients generally, I would say anecdotally, have less chances of detoxing if they ultimately say after 5-10 years in a MAP that they suddenly want to detox. It can be quite hard because they've become quite dependent on alcohol. We see lots of clients reach the end of their life through cirrhosis and liver failure. Many people get alcoholic neuropathies, And now at the Oaks, which is Inner City Health's long-term map site, like I mentioned, there's lots of clients who are living with alcoholic dementia. An example case to put this in perspective of how this can show up in terms of the long-term complications of alcohol. There was recently a client, this is, kind of an amalgamation of stories, that was living in their early 30s with a severe alcohol use disorder and had been at one of our MAPs for over 10 years. And sadly, through that time, had developed alcoholic cirrhosis and was having frequent challenges with hepatic encephalopathy and ascites. These are very medicalized terms for complications of alcoholic cirrhosis. And as a result, we had to have a goals of care conversation with this client and his substitute decision makers about whether or not he wanted to continue to participate in a MAP. For us, our mentality with our harm reduction programs is we're not here to tell someone what they are supposed to be doing, but we want to give them all the information that they need to be able to make an informed choice. And sadly, for this client, at the stage that his liver was at, continued participation in a MAP would be highly risky for his survival ongoing. So after having that discussion, he decided that he wanted to try detoxing, as that might be the only chance to avoid liver failure. So he successfully detoxed, but he remained at the location that he was living at, which was very understandable given that I've described them kind of like apartment buildings with their own mini communities. So not surprisingly, sadly, he relapsed a few days after detoxing because he was constantly in an environment that he was exposed to alcohol in. So we had another goals of care conversation with him and his family to reiterate the fact that sadly liver failure was highly probable in the short-term future. And this client chose to detox again. He was successful. But then when he moved to another site to do the detox to avoid the risk of relapsing, eventually he requested to, again, return to the MAP site to be able to be with the community that he knew. And this ultimately, sadly, led to the end of his life because he returned to the site and expressed that he was interested in continuing in drinking, accepted the risk of liver failure, and then he steadily deteriorated to the point of dying of liver failure. So this is sadly not an uncommon occurrence, as with the harm reduction, we're only slowing down this trajectory that a client could be on. Other challenges that we see is when our clients get admitted to acute care facilities. And that's because many aspects of acute care, surgeries, inpatient wards, diagnostics, have a lot of barriers for people in a managed alcohol program. And that can be just from the stigma about the fact that people are living with severe alcohol use disorders, are not trying to obtain abstinence, and are regularly getting alcohol. It can also be because many people have no experience with managed alcohol programs, and many acute care settings don't even have the infrastructure. So I sometimes talk with healthcare providers in acute care facilities about the clients that I see from our MAP sites, and they say, I would love to continue your managed alcohol program at my healthcare facility, but we don't have any alcohol, and we don't have staff that know how to administer it, know when to not administer it. It's just not possible. I'll skip this because that was an example of how stigma can affect somebody's experience. Another example would be how, just like for acute care, we also see MAP issues coming up in chronic care. So sadly, many of our clients at our MAP sites, they struggle to enter things like physical rehabilitation programs after a hospital stay, because there is no infrastructure at the average physical rehabilitation program for managed alcohol. Many subspecialty services or clinics don't necessarily have ways to accommodate someone who's living in a managed alcohol program. So as an example, how can a patient get an outpatient hernia repair if they drink alcohol every hour, on the hour, 15 hours a day? I mentioned before that many of our older patients or more long-term MAP clients are living with alcoholic dementia. Our supportive housing program sites are by no means equivalent to assisted living facilities or nursing homes. And we are now struggling to navigate what to do when someone needs nursing home level care, but still has this severe of a dependence on alcohol. This is another example of an anecdote that I can go back of how a client faced challenges with obtaining physical rehabilitation. So Now, as a segue into the Q&A section, I'll just talk about some future direction questions, and I won't go into too much detail about them, that we've been really thinking about lately with our maps at Ottawa Intercity Health. So, first question is, different maps around the country track the outside program alcohol consumption. Some programs attempt to track it as much as possible. So what I mean by this practically is, how many times is a client going out and buying outside alcohol? What are they buying, and how many drinks are they consuming? Other programs such as ours, we don't track outside alcohol at all. We might anecdotally track it, or a CCW or a nurse coordinator might mention to me that a client is consuming more outside alcohol, but we do not make efforts to record that in a diligent, accurate way. And I think this gets to kind of thinking about managed alcohol programs on that spectrum of harm reduction to alcohol reduction to totally abstinence-based therapy. Another question is, do the alcoholic beverage options make a difference? I've never really seen a research study that has said that the fact that Intercity Health's maps have wine, we get better outcomes or better participation from our clients, versus other programs may offer a spirit or a higher concentration liquor that they administer, or maybe other programs offer beer. Does anyone know from a health perspective or just global outcomes perspective if the specific alcoholic beverage option makes a difference? When we think about managed alcohol programs and compare them to something like an opioid safe supply program, they're much less flexible, especially when you make the comparison of the managed alcohol program sites that I work at. The participants have to live in-house, and they have to receive their alcohol on the hour, every hour, 15 times a day. Is there maps out there that are having greater success because they allow their participants to have offsite consumption? Should we be prescribing alcohol and letting people take it to go, like people that participate in opioid safe supply programs that show up to a pharmacy? Should we, at Intercity Health's map sites, be less stringent about the schedule? Should a client be able to come and access a pour as needed instead of being able to access a pour every hour 15 times a day? Should they just have 15 PRNs as the day goes on? I mentioned earlier that certain map sites in the country have community sites. Should every map site have this, for the possibility that a client may ultimately want to leave the site but still want to participate in some level of managed alcohol? And then lastly, I mentioned before about how maps can be challenging for people that have binge use style of alcohol. Is there a map program that would be better suited to them than, as an example, the very scheduled maps that I work at? Are we doing everything that we possibly can for comprehensive harm reduction? In the early days of the map sites at Intercity Health, the providers struggled to get participants living with alcoholic cirrhosis seen by gastroenterologists and hepatologists for standard cirrhosis care, because there was a stigma and a challenge understanding. But now, are we making sure that everyone living with alcoholic cirrhosis at a map site, if they want to go and get upper endoscopy to reduce their chance of having a variceal bleed, is that offered to them? Are we doing all the things that we can to reduce fracture prevention? Should we be prescribing people alcohol craving agents to reduce the amount of alcohol they consume while acknowledging that they're still going to be consuming lots of alcohol? And then lastly, are we doing things like this talk today to make sure that we're promoting the evidence and education around managed alcohol program sites so that they get adopted in more healthcare environments, not only the creation of more maps, but also so that more hospitals and other healthcare facilities are prepared and equipped to provide care to MAP clients when it's temporarily needed. So those are all my kind of future questions, and we've got hopefully lots to potentially talk about and lots for Jennifer to catch me up on in the chat. That was a whirlwind tour of the brief kind of history and evidence behind maps, the Intercity Health maps in terms of how we deliver them, as well as the challenges we face and our future directions. I really appreciate the chance to be invited to give a talk like that, and I look forward now to chatting with all of you. And I'll just briefly show my references slide if anyone was keenly writing down the annotations. If not, the slides will be available, I believe, after the talk.
Wow, you got so much in there, as promised, the theory and the practice, evidence and future questions. I think a lot of the questions in the chat do connect to what you anticipated. I'm going to go back to the beginning of the questions and start there. The first, thank you. The first question had to do with behavioral issues and timeout. I'm sure that was something that a lot of people were wondering about. So, what constitutes a behavioral issue? Especially in the context of this environment and the issues that you're dealing with. How do people understand what is going to be acceptable and unacceptable? Who determines a timeout? And what's the impact of that timeout on the individual and potentially on others around them, I guess?
So great question. I would say I should be careful because of the fact that that term timing out can be quite loaded. It does sound quite paternalistic in the sense that it sounds like something parents would say to a kid. You're timed out, go in the corner. But that is maybe not a bad reference point in the sense that the timeouts are typically an acute event. So to be clear, it's not about a client's ongoing behavior, or maybe let's say I talked about the fact that since our MAPs are in supportive housing programs and there's a partner housing organization, if they were quite frustrated with how a client's room was kept, it's not as if the client would be timed out because they're having ongoing issues with room tidiness. And it's not as if timeouts are administered for longer than one administration of alcohol. So nobody is timed out for the day or timed out because of kind of a long-term challenge like that. Typically, it is something that is observed in the moment and is happening just before that administration of alcohol. So it's not as though it's also in preparation for something later in the day. So as a result of the fact that you were incredibly abrasive towards another client at lunch and push them over in their chair, you miss your last pour of the day or something like that. It's typically, I would say the majority of timeouts are due to intoxication. And just the visible appearance of intoxication, that is the recording term that we use for when someone is deemed to be inappropriate to get their next pour, because we would be contributing to intoxication and harms from alcohol as opposed to trying to avoid the risk of withdrawal. But there are certain instances, like let's say being abusive towards a staff member or another client when waiting in line for a pour, that if it's felt to be related to intoxication, then that can also lead to a timeout. Generally, we try to avoid the tricky scenario of where a client's behavior as a result of alcohol withdrawal symptoms could lead them, well, they could have poorer behavior as a result of withdrawal. It's challenging to put into words, but that is something that we're trying to avoid timing someone out for that reason, because clearly in a system like this, now we're penalizing someone for having the substance use disorder that we're trying to help them with. We also find this is quite common at Intercity Health's opioid comparable opioid use disorder program, the managed opioid program, which is supportive housing plus injectable opioid agonist therapy. It's a fine line to describe, but we're always trying to make sure that withdrawal is not a penalty for someone. But yeah, just trying to put it in a loose encapsulation, that's really how timeouts work. The vast majority are when someone presents intoxicated or has behaviors that would suggest their behaviors and agitation are related to alcohol intoxication.
Yeah, I can picture that being difficult in people who might have other kinds of issues with impulsivity or anger or behavioral management in general, and potentially not responding well to what I assume has already been discussed, if not sort of contracted in terms of a consequence. And I understand what you're saying. It's when I think about timeouts and logical consequences, we try to make it to connect it to the behavior. So you're making the point that it's connected specifically to behavior associated with intoxication. Therefore, you don't need more alcohol right now. We're going to wait.
And many of our clients, it's not something that I talked about too much in the presentation, but especially in the early days too, of that trial and stabilization period, if they're coming in with a significant mental health history, they will preemptively have a lot of agitation as needed medications that are prescribed. And that's where those initial intake sessions and lots of teaching with the team of providers of this is where we're getting used to this client, and the nurse coordinator heavily interfacing with the housing workers and client care workers to say this behavioral action in another client you might assume is intoxication. In this client, it may be more representative of the fact that they have an acquired brain injury and a significant trauma history. So they will be more likely to lash out when something doesn't go their way or they feel threatened. And those types of teaching moments are really, really important because, yeah, I think we have to recognize, sadly, that maybe a reason why some of our clients in the past, if we polled all the employees at Intercity Health, did that client not have success in the managed alcohol program because they were timed out frequently for behavioral issues for the wrong reasons. And they went, well, this program isn't for me. I'm just getting timed out all the time. You know, this was supposed to help me with my alcohol. And were we doing enough to address non-alcohol related behavioral challenges?
So, connected to that, what about in people who have cognitive impairment, whether it's alcohol related or otherwise? Obviously their judgment and decision making may be impaired. So there was a question about what kind of screening and modifications there might be for those situations.
So, in the immediate term, that screening, we're always trying to think about that. And that's where that key of the clients are known to Intercity Health programming beforehand. And this, I think, is a really helpful component to how clients are included and admitted into our programs, is that they don't come from anywhere. So it's usually a program that they've been known to for quite some time. So it's not even if, as an example, a client shows up and receives some kind of drop-in primary care for a week at an Intercity shelter site, that they could be considered for participating in our managed alcohol program. We typically have to have known quite a bit about their healthcare and healthcare background, and then do that handover between one program site to another. So we're trying to get to know as much as possible. And often the teams that previously know the client before they move to a MAP site, they're helping in the early days of, you'll frequently, at our rounds or in emails or other forms of communication at our main office, will be saying, is this normal to see this client behaving in this way? Or is this what their behavior is like as a result of this brain injury or something like that? There's a lot of intensive handover that's attempted to be done. As well, I think we have measured expectations. So there's certain clients that have had behavioral issues that were quite well known with employees that have worked at the MAP sites for a long time, that only got better over the course of months and years. And that's why that kind of goals and long-term care planning phase can be years down the road, because the teaching for the staff can be that some of these behaviors will only change with time. And this may not be entirely only alcohol related, but part of the benefit of that regimented lifestyle that people participate in at least our MAP sites is that it can start to address behavioral issues from other pathologies. And I think there's maybe, especially for people living with cognitive impairment related behavioral issues, a lot of teaching to the staff persons that's comparable to working on a locked dementia unit or something like that, where it's important to educate the staff and potentially even other clients that this person's behaviors are not necessarily related to a choice of someone who has no cognitive impairment. So that's why in the early weeks or months when they're participating, they might act differently. So it's a comprehensive approach, but there's not necessarily one way. But it's for sure a really great point that many of the clients in the early months, behavioral challenges can be quite frequent. And I would say the threshold is very different from other healthcare settings. Many of the staff that work at our managed alcohol program sites came from working in shelter sites. And this is totally a sweeping generalization, but I think people that have worked in providing services to those that are facing homelessness and living in homeless shelters, expect a different level of tolerance for behavioral issues than in the standard hospital ward or standard outpatient clinic in a suburban neighborhood or something like that.
You mentioned that many clients have other substance use related issues. So I can imagine that also complicating assessment of what's going on when someone's behavior could be difficult, and also difficult in terms of assessing intoxication withdrawal and how to manage that. I wonder about sort of the prevalence, the substance use mixes that you see, and how those are managed. You know, we always talk about the risks of combining methadone and alcohol, for example, or benzodiazepines for managing other things. So can you give us a little window into that?
The biggest population, that the co-intoxication substances that we would see, you know, to be strictly a pure addictions medicine trainee, there's huge amounts of nicotine use disorder or tobacco use disorder, but doesn't lead to the same style of intoxication that's challenging for a managed alcohol program. But the biggest one that we see at our sites is cannabis. So especially at the Oaks, the long-term managed alcohol program site, cannabis consumption is quite high. And a few of those clients that I mentioned at that site that have kind of phased off of managed alcohol, this is all just anecdotal. This is by no means me saying that cannabis is an alcohol use disorder or there's something there, but anecdotally, a few of them have gone on to develop pretty profound cannabis use disorders. And as a result, they've stopped using alcohol altogether. So cannabis intoxication is, I would say, what our front-facing employees at those sites find the most challenging. When am I timing this person out due to alcohol intoxication? Am I timing them out due to cannabis intoxication? If I time them out too many times in a day because they're intoxicated from cannabis, will they get withdrawal? And that's also where the more experienced client care workers and nurse coordinators are doing some teaching. But in the short term, we view those as the same. If someone's intoxicated from cannabis, then alcohol is also off the table, because part of the assessment for timing somebody out is looking for features for withdrawal as well, to make sure that you're, again, not harming someone and why they're in the program by creating withdrawal. We do not have anyone that's participating, to my knowledge, in opioid agonist therapy of any form in our managed alcohol programs. I don't think that we have anywhere formally listed that that's an absolute contraindication, but it would be a significant discussion among all of the different teams involved. You know, we have a separate kind of opioid agonist therapy team that would have to give permission for that to take place and all those sorts of things. So it's not completely out of the question, but I would say typically our clients that are admitted for MAPS, it's really that their primary issue is an alcohol use disorder. And then same thing with, there is very little stimulant use at our MAP sites, as well as any other substances. So that's, I guess, how we don't have to address that challenge of someone that's on benzodiazepines or methadone. I would say benzodiazepines specifically is very rare to see in the practice style of the physicians and other prescribers that work at Intercity Health. It's not something that we really have a great infrastructure to be involved in benzodiazepine prescription. We will do it for detoxes, but otherwise there aren't people on regular benzodiazepines, and the mental health team branch of Intercity Health does not use benzodiazepines as a management for any mental health condition. They'll use alternative medications.
I want to come back to alternative medications in a moment, but someone asked about sort of the team. How much of the team is part of the MAP? How much do patients go elsewhere, or are there options for bringing specialists? Because I can imagine it can be difficult to get people to appointments.
So right now at Intercity Health, we have 5 physicians. We would have, it's fluctuating right now because we're hiring some new people, but in the teens of nurse coordinators, and then many client care workers at all of our different sites. The majority of the client care workers predominantly try to work at one site specifically. So they're typically quite experienced when they're working at a MAP site, as opposed to, we have client care workers that work predominantly at supportive housing programs that have no substance use disorder profile to them, or client care workers that are working in shelter-based programs. So typically they have kind of an area of expertise, but if somebody calls in sick or they do kind of part of their shifts at one site, then that can happen. The nurse coordinator is the same nurse coordinator on a regular basis. If you've worked in a hospital environment, I kind of give the example of how often nursing managers get moved around every couple of months at hospital environments to kind of keep things fresh and bring in a new management approach or something like that. That will occasionally happen at our managed alcohol program sites, but right now, one of our managed alcohol program nurse coordinators has been doing it, I think, for over a decade, maybe. So there can be a lot of expertise there. And specifically the types of physicians that we have a psychiatrist, an addictions medicine physician that's predominantly opioid focused, and then 3 general internists. In terms of how we bring in outside groups, there are certain consultants that are very well versed in the inner city health context and the types of clients that we serve and the types of resources that we have, and often the frequent requests that our clients have to have services delivered in-house. We often will touch base with them. Some of them, with the advent of the pandemic, will do lots of virtual care. Others will come and assess clients directly. Others, we will arrange specific times in their clinics to go see.
Is it safe to say, sorry, that that's like hepatology and psychiatry, or are there other sort of primary?
For the MAP clients, I would say hepatology would be one of the frequent collaborators. Psychiatry, for the Oaks, the long-standing managed alcohol program site, typically the mental health pictures there are much more stable, whereas the newer residents, the Richcraft Hope residents, people's mental health can be a little bit more up and down. And when Inner City Health only a couple of years ago still had a MAP program embedded within a shelter, then the mental health interface was quite a bit more involved. And that's because when our MAP sites were embedded within shelters, the flexibility in terms of our level of knowledge and experience with a client that was admitted was very flexible. So clients were being offered placement in a MAP program with limited knowledge about the client as a trial to see if things could be stabilized. And it would not be uncommon to see clients come and go on a weekly basis. There would be many clients that would go on to have success and ultimately move to one of the more long-term sites. But because it was based in that shelter environment and the behavioral issues, there was greater flexibility around the staff and the fact that we weren't trying to create a community with people that were living in these long-term apartment buildings, paying a nominal fee for rent, that sort of thing. Then we had lots of clients that were coming and going with also potentially an acute mental health overlay, and they would be regularly seen by mental health nurses or the psychiatrist.
In terms of those people who have some more stability and you're working on goal setting, one of the questions was how commonly you might reach out to family members to or include them in the goal setting process, or suggest that.
As long as the client is open, and then we typically will. And I think it's a good point that you bring up that we'll suggest it. You know, that may be a bit of a paternalistic projection, but I think a lot of the times the care providers are always kind of learning about, oh, you have a family, you have children or grandchildren, you know, maybe you should contact them back. And probably sometimes, you know, by accident, people are pushing that agenda too hard for their own reasons. But I would say that's a very common thing that we do. And, you know, one of the most endearing times at the Oaks, the one that's been around since 2010, is the winter holiday party. Unfortunately, it's not been running for the past couple of years due to the pandemic, but there are grandchildren that come for the Christmas party and family members. And just like for me as a general internist, I still do some inpatient work. I will call to give family members of our MAP clients updates about how their loved one is doing in terms of progress in the program or optimization of their chronic health problems. So there can be clients that have a lot of family involvement. And then, not surprisingly, unfortunately, due to the manner in which living with chronic homelessness and severe alcohol use disorders contains, there's certain people that sadly those bridges have been burned and we don't really see their family come back. And I think that's why with time, for speaking on inner city health experience with MAPS, pushing for those community-based, I shouldn't say community in the sense that they're based in the community, but in these supportive housing programs that create a real community in them, that helps to create relationships and families that sadly a client may have lost. But as we saw with the anecdote of that one client, where they were reaching the end stages of alcoholic cirrhosis, there is a double-edged sword to that success, in the sense that people are so entrenched in that community that when we think about detoxing, if that's something that's important to prolong their life, when they hit end stage alcoholic cirrhosis, it can be really challenging because that's where their family is. And it's very challenging to be detoxed and abstinent from alcohol if everyone around you is consuming alcohol.
So there are a whole bunch of questions around, the impact of someone actually passing from alcohol related complications on people around them, but also around how to support people who might want to decrease their use, and whether you use naltrexone or other medications, how you get to that point in a conversation and how that's managed with people.
For clients that are demonstrating obvious signs of long-term complications of alcohol that are affecting their health, we'll always kind of paint out to them that this is sadly a consequence of their alcohol consumption. And we are not trying to suggest that as a result they have to stop consuming alcohol, but if they want to mitigate that complication further, that any level of reduction may lead to benefit. So alcoholic neuropathy is a very common one that clients will complain of, that burning, awful sensation. We'll rule out other forms of neuropathy and then say to the client, sadly, with continued alcohol consumption, this may only get worse. But one of the ways that you could prevent that would be going down. And going down could be less pours in a day. It could be less in the volume at each pour frequency. And we can reevaluate from there. Other clients will spontaneously identify to us at those occasional check-ins about, do you ever think you're going to reconnect, with your children? You're always talking to me about your children. Is that something that we could help you with? And they say, yeah, I might want to think about that one day, but I know that my daughter would never accept for me to be in her life again if I was drinking this much. Oh, okay. Well, do you want to try methods to try to see if we can help you cut down? So we do have clients in our programs that are on medications like naltrexone, acamprosate, and the gabapentinoids. That I think would be a great area for people that are really research oriented to start looking into, if that could be combined in a way that would lead to either mitigating and prolonging the level of harm reduction by mitigating complications towards the end stages of alcohol consumption, or if it is in a client's interest, as a bridge to abstinence, or as probably a more realistic bridge to decreased alcohol consumption, to make a different form of housing possible than a highly regimented form of a MAP like our MAPs, where 15 alcohol administrations a day for a lot of the clients is really challenging to find a location for them to live at outside of that.
Is 15 standard? Like I'm wondering about sort of, the median mode, like how many people actually have 15 pours a day? And if people are looking at reducing at all, does it tend to work better to skip up, one pour or two pours versus reducing the amount in a pour?
I would say that for a lot of newer clients, once they get stabilized into the program, 15 becomes quite standard, just because of the severity of the alcohol use disorders that they come in with, that ultimately that's what's taken, that's what's needed to stabilize them. But once people get past that initial stabilization phase, or are kind of in the chronic care and optimization phase, it's not uncommon at all to see clients that miss pours for a number of reasons. They're sleeping, they decide to go to bed early, they're not feeling well, they just don't feel that they need it. So many clients that it's not uncommon to see that the number of pours that they actually receive over the course of a day is more like 10 to 14. And then pretty rare to see clients, I would say less than that, unless it's an intercurrent illness or they're reaching the end stages. We don't have any clients that I would say are well from a physical health perspective that are only receiving 5 pours in a day. And that's probably just representative of, if they're at that point, they came from a much higher severity of alcohol use disorder, and now they're incredibly motivated in an action phase of change to get out of the program and taper their alcohol consumption off entirely.
Speaks to how difficult it would be, though, for someone who needed hospitalization for an acute care to be dealing with whatever the acute situation is, plus withdrawal, when that's kind of, you know, the standard.
We're often trying to send letters that get into kind of a very granular, science-focused calculation about the amount of ethanol that someone's taking, or to try to say to the hospital, you know, at the hospitals that I do inpatient work at, we have beer, we have sherry, we occasionally have wine. So really trying to make sure that the options are available for the client to receive a comparable amount of alcohol, while also trying to educate the healthcare team that may be involved with their care that, well, make sure that this is their goal. Don't force it on them. If they want to detox, that's an option too. And at the same time, if they're really sick, don't go overboard, because they may have a decreased tolerance. So it can be very challenging, especially if the hospital says, this is not something that we really do often. It's not really feasible with our ward team or with what our pharmacy has in stock, and all those sorts of things.
It would be a huge challenge. There are still other questions and comments. I'm going to choose this as the last one because of time. What parameters are used to define the success of a client on the managed alcohol program? You know, for example, in OUD studies, we look at decreases in all-cause mortality, diminished, you know, infectious diseases. Although I will say that in OAT, one of our major outcomes of success is retention and treatment. So anyway, I put that to you around.
I think it's a great question, and definitely I don't think there have been enough studies on the MAP programs in Canada or the ones that exist elsewhere to say that this is a common definition that MAP physicians or nurses or whoever's involved in MAPs would say these are accepted norms. I think the decreased use of you know, that global kind of catch-all of healthcare services and costs would be one. That's really something that those that are involved in MAPS would pride themselves on. And then seeing if there was a way that we could estimate a decreased early death, or kind of like the qualitative years that this person theoretically may have gained on the pathway that they were on. If there was a measure of that, I think that would be great, because you know, there's so many clients that we have that when they do cross paths with someone that they used to work with in the shelter system or in a primary care setting or in a hospital care setting, that the people are just absolutely shocked that this person is still alive with the trajectory that they thought they were on with their alcohol consumption, and with admissions to the intensive care unit with complications from non-beverage alcohol use, or even things like people that have alcoholic cirrhosis, but the damage slows down considerably when their alcohol administration is in a tapered, kind of measured fashion from what they would have had outside a program where they could become as intoxicated as possible on a regular basis.
Great summary. It's 8:30. That hour and a half has flown by. This was an absolutely amazing, intriguing, and practical talk. I hope that we can find other opportunities to continue this conversation, because I think there may be people who are interested in looking at how to adapt and modify. And as I said, I think about so many other questions, from costs and structures and billing and, you know, all of these other things, like, you know, metrics that we talk about. So thank you so much. Everybody, please complete the evaluation. Please remember to join us for our last webinar of the season. Tally Cahill, also from Ottawa, will be talking about naloxone, same but different, naloxone in bystander response versus SCS, site overdose protocols. And I think, yeah, lots of interesting things to think about how naloxone is being used there. Happy Nursing Week. Last thing I wanted to remember was, for anyone who has contemplated submitting an abstract proposal for the Medify conference, which is September 23rd, 24th. Please do so, whether you have a clinical interest, pearls you think you'd like to share, a new program you'd like to let people know about, a research project. We welcome your submissions and look forward to planning a conference that has something for everyone. Graydon, thank you so much. This was really wonderful.
You're very welcome. Thanks for the opportunity, and thanks for everybody participating in the chat.